This session is presented by Bill and Melinda Gates Foundation. Can we please give them a big round of applause?
Okay, good morning. Thank you very much for being here. Health is a very big subject. We are going to cover some ground today, but it may not be to the satisfaction of everyone here. But what we'll try and do is, and let me tell you the outcome that we're looking for. We're trying to see what are the 4 or 5 things that public and private sector should be doing to fundamentally improve the quality of healthcare delivery to you and me in this country. And in order to get there, what should we be thinking of today? Should we be thinking of re-architecting the entire system? Should we be talking of fixes? Should we be talking about attitudinal changes? Should we be learning from other countries, and some of them in our very neighborhood who've done much better in some ways in delivering healthcare, despite not necessarily having the same economic indicators? And where is the accountability for all of this going to be as we want to set out on these goals and targets? So those are some of the things we're going to talk about with my guests, who are a combination of practitioners and policy experts who've all spent considerable time and effort studying the healthcare system, either from within or outside. So what I'm going to do is, I'm going to ask each of our speakers to speak for about 5 or 6 minutes and define the landscape as they see it from their perspective. We'll use that to build on our discussion further and then try and arrive at the outcomes that I talked about in the beginning, at which point I'm hoping that you too will have some questions and would love to throw them at our speakers today. So let's use that and begin with Maitreyi, who is also a Rajasthan resident, and she's happy to be back home, and use perhaps some of the examples from right here to illustrate her points. Maitreyi.
Thank you very much, Govind. So I'd like to make a few points about healthcare in, closer? Okay, is that better? About healthcare. I think the first point we need to realize is there's been huge progress. And we need to acknowledge that progress. So over the last 2 decades or 3 decades, there's been a huge amount of progress across a range of indicators. And I think we sometimes forget that when we are talking about all of the challenges, we forget how much progress there's been. I mean, just to give you an example of fertility decline, something that often people don't realize is that we're at replacement fertility. And some of Indian states are actually have fertility levels that are lower than OECD countries. So there has been, and similarly in many other...
Which means that, to illustrate it more simply, it means that someone in, people in the state of Kerala are older than maybe even Scandinavia.
People in Kerala are?
Older, they are.
No, it means...
Or getting older faster than...
There are 2 separate issues.
Yeah.
There is an issue of aging, and yes, we are at a stage in the demographic transition where aging is becoming a huge issue, and in the next 10 to 20 years, aging is going to become even more of an issue. But fertility decline is how many kids people have. So replacement fertility is 2.1. So basically, you have to have 2.1 kids to replace the people that die. And we're almost at replacement. We're at 2.2. Okay? And I'm giving you just one example, and that fertility is just one example, but often people talk about overpopulation and other things. You know, the momentum of population is going to stay, but fertility is on the decline, and that's a huge success. Similarly, you know, even in mortality, in all kinds of indicators we have made huge progress. That said, levels are quite low in many indicators for our level of income. So for India's income level, as compared to other countries of our income level, our levels are pretty low. So there's progress, but there are also huge challenges. I would like to take your point of learning from other countries. I think that Bangladesh and Nepal in particular have done extremely well, and there's lots to look at. The third point I'd like to make is something that you mentioned, the public sector and the private sector. There's another sector, and that's community-based, community-driven development programs that are actually at the heart of delivery of many services. And they comprise a demand side. They comprise the core of behavior change. They comprise the core of changing social norms and values. So I think that we cannot forget, and we cannot move away from the fact that wherever there's been huge progress in whichever country, community-based systems have been extremely strong. So I'm going to stop there. Don't take more.
Dr. Trehan.
Thank you. So whenever you start talking about healthcare, you say, where do you start? Because we have two very compelling problems ahead of us. One is we have a population which is any country you want to compare yourself to is 4 or 5 times the population of that country. The allocation of our budgetary health budget is much less than them. So that being the starting point, today we have that famous Indian paradox with everything. We have the best and the worst of both in healthcare. So as Maitreyi said, we have people are coming from all over the world to access healthcare, but at the same time, if you just step out of the cities, there is such a dismal state that you actually feel ashamed of being in your country. So we have to actually stop being interventional. We have an epidemic here, we go intervene there, we want to, now polio is coming up, let's vaccinate polio. So there is no cohesive policy which says to build a healthcare system of a country, this is the stack. On the other hand, we have a double whammy because we have the highest incidence of communicable diseases and we have also the highest incidence of non-communicable diseases. We are the center for diabetes. We have 70 million diabetics already in India, which we estimated would happen in 2030. It's already happened. We have 70 million pre-diabetics who are going to become diabetics if we don't check it right now. Cardiovascular, we have 60 million people with cardiovascular disease and another 60 million waiting to go down the path. So you must look at it in a complete continuum to say, where do we start? So the starting point is one, decrease the burden of disease. And basic civic amenities like clean drinking water and sanitation and all that will actually halve your burden already. So we have to stop getting obsessed with building hospitals, beds more and more because that will take a long period of time and we don't have doctors. So what you can do today is to make your system in such a way, one eye on preventing disease, the other eye on utilizing the services that are on the ground today. They reside grossly in 3 areas. One is the government facilities, private facilities, and the NGO. You mean not-for-profit institutions like that were built in the past by philanthropists and stuff like that. Each one has no connection with each other. In fact, government blames the private sector denigrates the government sector. We need to break down these walls, take it as a one service available to the people of India. If it stands on the land of India, it first belongs to the people of India, then it belongs to me or the government. If we do that, today we have enough capacity on the ground to improve the healthcare facilities by 50%. You can serve 50% more people without spending another penny on infrastructure. So somebody has to actually get down to it and say, look at India, healthcare as we are going to build the full stack. Okay, now one thing has happened after a lot of discussion on universal access in the last 8 years. We've been working feverishly with Health Ministry. Niti Aayog has made a big difference because before you had to run around Health Ministry, Finance Ministry, this ministry, MCI, Niti Aayog was given all the powers to make this universal access program. Okay. They've done a good job in identifying, starting from the wellness center on the ground. Now, when it happens, how well it will function is another theoretical situation, but policy-wise, identification, we have a starting point. So wellness center will be the first point of contact for anybody who lives in the village. They are the ones who are going to be able to refer them to the next step, Today what happens is there's no facility in the village. People get fever, then they sense after 4 or 5 days that the patient is not getting better. It looks like he's going to die. They get into whatever they can find, whether it's a car, ambulance, whatever, they run to the best hospital they can find, which is also expensive, but it's late entry there. Now, look at their dilemma. A villager who has got limited means gets to a hospital in the intensive care unit, on a ventilator, all sorts of antibiotics required to actually treat him, with a success rate of, by the way, 90%. But the cost of delivery of such a level of medicine is very high. Now, they are now already in debt. try to get that because you want best for your family, especially for your children. Then if they don't survive, now they are hit with a bigger stick to say, I paid 15 lakhs of rupees trying to save my child, I sold my house, I did everything, but at the same time, I don't have my child. So these are the things that we need to address. That security system, that safety net is missing. Every country that has been successful, and as you mentioned, Bangladesh, Nepal, and all these guys may have done, they have provided that safety net better than we have. And it's the starting point where we must get to from now.
Okay. I'll pick on those numbers that you said. So you said about 60 million affected by cardiac disease and another 60 million will get it if we don't pay attention, right? So that includes people sitting in this audience also, I would imagine. And I remember the figure for 1990 was about 25 million. So we've more than doubled in less than 20 years.
Yes, absolutely. Okay. It's rampant.
I want to say two things. The first is in continuation with what you said, prevention is better than cure. The best of all worlds is where people don't get sick. And there I want to continue where Maitreyi was saying that we've had gains in India. I worry that there are fundamental flaws in what we are doing in the way public policy is organized in India, that higher economic development, higher GDP growth in some ways is actually making things worse, not better. Okay? And I want to give you 3 examples of that sort of phenomenon at work. The first is air quality. Okay, when India was a poor country, we did not have an air quality crisis. Today, along with China, we are one of the worst places in the world in terms of air quality. And that's an example where getting richer made things worse, not better. A second example that I would point to is road safety. When India was poor, we didn't have roads and vehicular traffic of a high magnitude. We now have the NHAI, we have the Pradhan Mantri Gram Sadak Yojana. We're building roads, we are buying vehicles at a very high rate. And we've simply not thought through the institutional infrastructure of road safety. So we have an upsurge of accidents and people are getting harmed. And then you could think about health care as a way of alleviating that. But I would rather go to the root cause and say, we need to get our road safety right in the first place. So getting richer can make things worse. And the third, of course, is what we're seeing in urban India, that our basic designs of the cities are conducive to a sedentary life. Whereas right at the foundations of urban planning, we need to be creating a world where people walk to use urban mass transport, where people have access to parks, so that all of us will become healthier. And because we failed to do that, all of us are getting trapped into a world of personal transportation, and then we get a great upsurge of cardiovascular disease and the other degenerative diseases of old age. So these are 3 examples, but I wish to make a deeper point that we should not assume that getting richer makes us healthier. If anything, there are basic mistakes being made in India. And these are not mistakes that come under the administrative structure called the Ministry of Health, but they are all over the landscape. Okay? If we build cities in earthquake zones and we don't do the appropriate engineering codes, then we're setting ourselves up for a catastrophe when the next earthquake comes along. So this is my first concern, that we need to be far more prevention focused than we are today. My second argument concerns healthcare more directly. We in India are drifting into a healthcare system that was not adequately thought through, and it is increasingly de facto becoming a large amount of transactional relationships between a patient and a private provider, and this transactional relationship works poorly. Most of us are not equipped to understand the service offering of the healthcare provider. We're not equipped to take care of our own best interests. And because it's a transactional relationship, because it's a one-shot prisoner's dilemma, the healthcare provider has no interest in my health either. So the healthcare provider views it as a patient walks into my door, I'll try to do some things while I can, but for the rest, I don't have a deeper incentive to make that person healthier. And there is a fundamental gap between a healthcare system that tries to make me not walk in the gates of a hospital versus a healthcare system that lets me meander and make many mistakes and do things wrong and just fix me up as and when I show up in hospital. And I think we need to re-architecture our thinking on healthcare from that point of view.
Okay, great. So, couple of points. So, you're also saying that the system of private providers is broken because the incentives are wrong. So, how do you correct those incentives then? Because 80% of Indian healthcare is private, isn't it?
Yeah. There are two broad ways to change incentives. The first way, a very famous example, is the United States private system that is called Kaiser Permanente. This is a network of providers, a dentist, hospital, all of them coming together as a network, which gives the individual a contract saying, I'm going to be your healthcare provider for life. Okay? And you're paying a flat fee to them. So when anything goes wrong with you, you're going back to this one healthcare network. This is a good arrangement because now they have an incentive to keep you healthy. Okay? So if they are on the hawk for every surgery that I have to go through, then they have every incentive to actually make me healthy, to make me go into their doors less. The second line of attack is to create conditions where health insurance companies and networks will negotiate fair play and pricing with healthcare networks. So these are the two big ideas on how to change incentives.
Okay, Dr. Trehan, let me pick up on Ajay's points, and I'm sure you want to respond as well. So the first is that is our healthcare system fundamentally designed in a way that we only fix what arrives, as Ajay says, as broken on our doorstep, and before or after there is really no concern what happens?
No, Ajay's point about Kaiser Permanente, what we call the HMO model, the Health Maintenance Organization model, is a very good model. But it was tried hugely in the early 80s, late 70s, early 80s in the United States, and only Kaiser Permanente and one other survived. The rest of them folded because of the fact that in California, Kaiser Permanente is based in California, and health awareness in California is much more on an average, and it works very well for them. In fact, we have tried to replicate it in India, which I describe as the annual health maintenance contract. That if people would give you X amount of money per year to insure themselves, and we would take care of their health in all aspects, basically keeping them healthy, because their stake and our stake is into keeping you healthy. So that program works. It's a very complex program, and there should be enough people willing to come on board to make it happen. That's how the HMOs collapsed, because not enough people who were healthy came on board. But in California, the companies and all that have, so it's a good model, no issues. You're right that over the years, that bond, that patient-doctor bond has actually broken down much to our distress. And there are many factors to it. One factor is, like you said, everything in life has become transactional. So emotion has gone out of most services. So you pay and you get. But medicine was a bond which went way beyond that, because it was like the doctor cared, and you actually had that every part of your life was actually discussed and kept in touch, more like a friend. It became more like a trusted friend. Now there are many things that have happened. One is the fact that today, because of the cost of delivery of healthcare, now by the way, it costs 75 lakhs to 1 crore to build a decent hospital per bed. So you're saying, if you want to make 200 beds, it's no less than 200, 250 crores that you'll have to spend. So then the cost of delivery also becomes a lot. So people then find that there is, in the work that they have to do is, so they will come for only tertiary care over there. So that family physician has disappeared because everybody has gone somewhere else. So now I think we need to recorrect, and this Kaiser Permanente model is a good model. And I think if we can make it happen to us in a different form in different areas. But by the way, let me also tell you, like Maitreyi said, there are some very good schemes. We are sitting in Rajasthan, the Padma Shree Rajasthan scheme for health delivery, which covers everybody, every citizen of Rajasthan. There's one in Andhra which Ajay was just saying that on the surface it looks good but has not really worked well. So challenges are huge and we cannot actually paper over, but point is we need to find the starting point where we take care of people's health, try to keep them healthy, and then provide them sequentially the care that they need at different levels.
Maitreyi?
So is the question still about the private sector? And so I think I come from a slightly different angle. I think that yes, people, 80% or so people, expenditures are, well, not people, but 80% of all expenditures are out-of-pocket expenditures. And that's a real issue. It hurts the person who's the poorest probably much more than the person who's a non-poor. I think regulation is a big part of it. I think that our regulatory system, as far as the private sector is concerned, is at best, it's a fragile system of regulation of the private sector, which distorts the incentives. So that distorts the way in which the private sector behaves. And I think that the private sector, I also want to sort of bring in the non-government sector into this. The solutions, again, and I know I'm repeating myself, but the solutions are not always the top-down solutions. So whether it's a private system or a public system, I think in our heads we have begun to think about these as monolithic top-down systems which are very supply-driven. I think there's a demand side to it, and I think that there are ways in which people solve their health problems in ways that are more sustainable and that are around prevention. The other point I wanted to make is that I think when we talk a lot about the private sector and the way in which it behaves, we sometimes forget that the areas that probably need the greatest attention are the areas that are the most underserved. So Adivasi areas, for instance. In Adivasi areas, the private sector behaves very differently than it does, say, in Delhi or in the large cities. And what are we doing about that? So where are we going with that private sector?
Yeah, so let me put that to Dr. Trehan. So there is a huge conundrum that stares at us, right? So the capacities with the private sector, the money is, I mean, with the patients don't have the affordability to come to the private sector, and yet they want to come to the private sector. We discussed a study just yesterday, which was released, which interviewed thousands of women in Rajasthan, and one of their key points was that they did not trust the government system, and they typically came to the city or town for maybe advanced care and ended up spending a lot of money as well. So where do we attack this problem and how?
Like I said, it's a huge problem. I mean, like any other problem in India, it's not, but health being so vital to a society or a country, we need to pay a lot more attention to it and take out all the kinks that we can. And like I said, because it is so chaotic, we have actually made that stack to say, if you have a reliable local center, which is supposed to be the sub-center which was created in the actual system which never worked, now we have renamed it as wellness center. Okay, if we can make that wellness center function, which is not only responsible for treating people, but also responsible for the civic amenities. Now you look at, there are hundreds of schemes. There is Swachh Bharat. Swachh Bharat is supposed to provide all the sanitation and all that toilets and cleaning and all that. If you make, these are all twins. Health delivery and preventive health are two actually joined at the hips. But we have no connection. You talk to the two chiefs, they have never talked to each other. So I'm saying, these are not, we have gotten to the moon. This is not rocket science. It is somebody who cares. First you have to start caring, just not say giving slogans. If we start caring, this has been solved by many countries. You have to allocate enough funds so that people have the security. I'll give you just one example. Today, a bypass surgery in US costs $40,000. In India, in the best of places, is around 2 lakhs of rupees, okay? Not more than 2, 3%, 5% Americans can write a check for $40,000 for their bypass today. Not more than 5% Indians can write a check for 2 lakhs. So the problem is the same, but the solutions that have been provided by some other countries, that safety net of healthcare is missing, and the sooner we get there, the better our country will be. Because one more very scary, which is very depressing, is that 2 to 3% population of India goes from above poverty line to below poverty line every year under the burden of healthcare. Now that, if you are making
medical
people
emergency
poorer every year by providing them healthcare, that is a disaster. So the sooner we get down to the ground and try to make these schemes and all these solutions work, the better, the prouder we can be of our country. So we wasted 71 years, by the way. Now, in the next 5 years, if we can make a difference, that'll be a happy...
So we'll talk about Swachh Bharat and Ayushman Bharat. I mean, two programs which intersect in many ways at the preventive and the curative way. But let me ask you another thing. You're also fighting a perception problem, and this is to you, Dr. Trehan, that, there are people, for instance, and we see a lot of news reports, who spend a lot for private care, and sometimes for a dengue case, it could be, you could have spent 15 lakhs for a child's, let's say, it's not operation, but it's really maybe ICU and hospital stay, and then the child passes away, and people are wondering, what did I pay so much money for, and hasn't the hospital fleeced me? So now these are isolated examples, but they leave a feeling that the dichotomy between what private delivers and private charges is so huge today that we have really created an unequal and unfair society.
So you have to look at the components of everything. You just can't paint everything with the same brush. The point is, it is expensive. Do you know that anybody in shock, in dengue shock, to try to even save them, and you will have 50 to 75% success in those cases, will require plasmapheresis exchanges, which cost 2 lakhs of rupees by itself. So there are components of this where if you want to give the albumin substitutes, it's 50,000 rupees. You buy it for 50,000 at the hospital. So these are not things that the hospitals have actually inflated or anything. People should look at the bill and point out that what was not done. And if they are charged, yes, then of course the hospital should be taken to task. There has to be transparency. I think that there are 3-4 things happened there. Now, as I told you, even anybody would feel bad for that parent who sold his house or whatever it may be. And then the media will say, they looted, they do this. Did you go to the hospital, check the bill, give the hospital the opportunity to explain what happened, and then went out to press? I think that's fair. But this sensationalism, irresponsible journalism is also not good because it disrupts society. It may hurt the hospital, but it hurts the larger society, because what happens is, then you become defensive. Then you say, if you can't afford it, should I use these medicines for you or not? So ultimately it comes down to the safety net. That safety net has to be provided for our people. It is a tragedy where somebody has to sell wife's jewelry and home to access healthcare. I think it's a tragedy, and we are very ashamed of it.
Ajay, do we have the preconditions for the kind of changes or bring about the changes that you're talking about?
I want to link up to what both of you said about the behavior of the private healthcare system. There is a role for more and better regulation. Okay? So today we have evolved a completely unregulated healthcare system, and that has problems. The Medical Council of India has not really worked out. It does not exert regulatory constraints upon its own ilk, and we need to do more. So I think that there is a case for more regulation, but I also think that you can only go so far with regulation. There is a deeper problem, and that is incentives. So I think we need to work on both tracks. That question one, how do you address some basics? Can we knock out some of the left tail events on the behavior of the healthcare system by bringing about a little more regulation, a little more legal obligation, a little more legal liability? There is a case for that, but we should not pin all our hopes on that.
So you say legal liability on hospitals?
Yeah, on healthcare providers all across.
And you feel it's not enough today?
We have nothing today. So if you walk up to an average healthcare provider in India today, there are essentially no enforced legal liabilities. I'll give you an example. Under the Clinical Establishments Act, the hospitals of India are supposed to have a price card that is displayed in the public domain? How often do you see it being shown?
No, I'll differ with you there. There is a lot of enforcement there. The cards are available everywhere. They are stuck on the wall. The fact that how much free services you are providing from that hospital is also big board outside the hospital and inside the lobby. So I think that many things have changed.
So
and also the point is, no, listen, there may be many fly-by-night operations. Now that is like...
So my team did a random sample of 100 hospitals in Delhi. Okay? Now you could argue...
When was that?
Last year. That the best enforcement of the Clinical Establishments Act would be in New Delhi. We used Google Maps to make a master list of all the hospitals in Delhi. We identified a random sample of 100 of them, and we went up and acted like fake patients and asked basic questions, and in about 80% of the hospitals, the elementary provisions of the Clinical Establishments Act were not being met. So I think there is a big enforcement gap, and the Clinical Establishments Act is quite basic.
I mean, so it's an enforcement gap, it's also a compliance gap. Isn't it?
It's the same.
Yeah, okay, it's the same. No, what I mean is that a hospital could also say that I want to be seen to be complying with this and be proactive rather than...
See, there are many things. We created what we call NABH, National Accreditation Board for Health Sciences, right? That has been very, to accredit a hospital, you cannot do more than 200-300 a year because there's not enough manpower to go and assess them. I sit on the board of it, so I know how much we have been trying to do. So they are to comply because their reports and all their data becomes transparent. So I think things are happening from that point of view. But our need is on every end. It's not only on regulation, but also it is, like you said, MCI was a political body. The government actually created it and kept it alive by election processes and putting their people in there. So it's not like the doctors did it. It's basically the whole system is unweighted. Like I said in the beginning, where do you start?
Okay.
But the point is that people today need help today. So it's not that we should get stuck in all this debate. More than that, try to create a practical system where we can provide relief to the people starting yesterday.
Right, okay, so we're going to come back to Ajay, what else did you find in your survey?
Just that this was one paper. We have many projects of this nature, but this one paper we found that essentially the medical fraternity does not take the Clinical Establishments Act seriously.
Okay, Maitreyi?
So I want to go back to something that Ajay said. I think when we're talking...
and also maybe how does this contrast with the work that you've done or seen in neighboring countries? How enforced?
So I think India has much more of a curative, high-end model, much more of a focus on one end of the epidemiological transition. Okay, so there are two ends. One is really basic primary healthcare. The other is the very high-end healthcare. We have both ends. So both our tails are very, in terms of morbidity, the burden of morbidity is high on both sides. So we have NCDs, non-communicable diseases, are very high, but also primary healthcare is poor. So you'll find both ends being very high. In Bangladesh in particular, the focus has been on basic health. And so they don't have, so Bangladesh actually doesn't have as good of a high-end healthcare system as we do. And so they do come to India, for instance, for medical tourism. But they have a very strong basic primary healthcare model. And I think that's something the Bordia Commission also talked about way back in the 1950s, that we needed to have a strong primary health model which takes into account all of the preventive issues. So we're talking about dengue right now. We're talking about the ways in which dengue can be treated and the amount of, how expensive it is. Why are we not talking more about vector control? I mean, the issue is why are we having cases of dengue in the first place? Because we're not talking as much about the links with sanitation, with the links with mosquitoes, the links with bed nets, the links. There are so many low-end, low-cost ways in which we can do vector control, but our focus is on the curative model. And Bangladesh in particular has focused quite a bit on the preventive model. And there's a history to it, and the answer is not, and a lot of people that talk about Bangladesh say, oh yes, it's because of NGOs. The fact is that it's not entirely about NGOs. The state in Bangladesh created an enabling environment such that both NGOs and the state could function together And so the kind of the tripartite of the state, the non-government organization, and the private providers are almost in tandem with each other. Of course, there are problems and other things, but so these countries have focused quite a bit on basic healthcare, and I think that's
right.
That's
so it comes back in a way to in the fundamentals and the foundational aspects. And Ajay wanted to come in and.
Yeah, I just want to say to everybody in this room, if you live in India, I just want to ask you, do you sleep in a mosquito net? Please raise your hand if you sleep in a mosquito net, okay? I see maybe 20 hands, and please reevaluate your life strategies.
So let me come back to another point. Let's focus on, let's say, cardiovascular diseases, which are on the rise, as we just said. You said another 60 million people are going to get it. Diabetes, which is also on the rise. Now, if I look at cardiovascular diseases specifically, the key cause seems to be bad food, or one of the key causes is bad food, air pollution, high cholesterol. Tobacco is actually a very small thing and diminishing from what I can understand, and there's of course blood pressure. So now the thing is, if these are the components of what's causing most of our non-communicable disease problems, how do we then, or are there sort of quick fixes to at least get people to focus on this, so improve the quality of food you're eating?
You have to change behavior pattern. I experience this because a lot of my patients come from Punjab. Punjab. So you give them, you bypass them, and now you say you must lose 10 kilos because you're diabetic, you must get yourself. At the end of it, say, Dr. Saab, asi te Punjabi hain, parathe dikhayenge hi. So what do you do to that guy? I mean, I've wasted 10 minutes telling this guy what he must not do. So we have a huge problem. People have become so sedentary. If they could go to the bathroom in a car, that's what they would do. This is something, and I blame civil society for many of the ills that we have. You talked about air pollution. Now, I don't see protests from the civil society. They always say, Dr. Saab, aap kya kar rahe ho? What am I supposed to do? You are all supposed to be out there on the street. You saw what happened at Nirbhay's time. Everybody was out there. The whole regulation got changed. We are very passive ourselves. You talk about dengue, we are just going to wait. The government doesn't do a damn thing. We'll just wait for the next season to come, and 20% of us will fall, and then again the next season will come. We don't need, in some of the programs that we have started from Medanta, we don't find any traction from the RWAs. They say, yahan spray kar do, sab theek hai. They won't do it themselves. So I'm saying that we are also to blame. The government is not to be blamed for everything. Our attitude is the old British. Okay, the government controls everything, they will do everything. That's not true. We are 71 years away from that point. We should take our own destiny in hand. Why are we letting our children, grandchildren choke? Why? Have you heard a voice? 10 people will stand in Rashtrapati Bhavan, including me, and go to TV and say we are all going to die soon. And I've published pictures of lungs of Delhi residents versus Himachal residents. And you will see the difference. Delhi lungs are all charcoal grey, and the Himachal ones are baby pink. So we know what it's doing to us. It's not a mystery. So I think that we should wake up as a society, and at the same time force the government to do certain things which are necessary for a healthy nation. Otherwise, the lung disease will kill enough so that all the gains you make on any healthcare delivery will be negated just by these kind of things.
So this is actually a really, really important point Dr. Trehan's raising. In India, as compared to, say, Brazil, for instance, the people's movement for health is much more muted and not as strong as, for instance, demand for education. So the people's movement for education, although not extremely strong, is much stronger than people's movement. So people are demanding education much more strongly than they are demanding health. So what's going on? Why are we not doing this? You find that there are certain issues that come up as blips, but there isn't enough of an organizing demand side movement around health, which has been a very puzzling phenomenon in India as compared to Latin American countries such as Bolivia or Brazil. So it's an important point.
Okay. Ajay, why doesn't that happen? Why don't we see a groundswell movement. So, for instance, I mean, I come back to the example that a child dies in a hospital, a crowd lands up, and this happens in my home city of Mumbai quite often. People want to break the hospital, but at the same time, there's no, there's no concerted feeling to mobilize on something more basic, on something long term.
So I think it's an intellectual failure. We tend to think of health as healthcare, whereas, for instance, air quality, it's not healthcare, and it is supremely important. And as I was saying, we as a citizenry have yet to grapple with the idea that actually getting richer can make things worse. It's an extremely troubling and gloomy view of the world, where you think that when we build the National Highways Authority of India, we have created carnage on the roads, and a lot of people are going to have their bodies broken and they're going to die because of low health, because of low road safety. So I think we need to think that health is not a vertical silo that is the work of a Ministry of Health. We need a health risk orientation that spans all across various aspects of government, and we need to be far more conscious about the deep determinants of health. And getting rich does not necessarily make it better. In fact, where we are on the Indian developmental trajectory right now, getting rich is making things worse.
Okay, I'm going to come to questions in about 4 or 5 minutes. So let me pick up very quickly on the two schemes. One is the Swachh Bharat scheme and the Ayushman Bharat. I mean, two different ones, but both large in scale and sweep. Ajay, what's your sense so far? So the Swachh Bharat has objectives whose outcomes will encompass a lot of things. It's not just about bringing about cleanliness, it's not just about disposal of, let's say, sludge, fecal sludge, but it's also about improving the quality of lives. It's also about making us healthy. How far do you think we've come from your perspective or standpoint as a...
So Swachh Bharat is bang on track in terms of the objectives. Okay, it goes to fundamentals of preventive health, the old style 19th century public health. Okay, so it's bang on track on the objective and on the emphasis. On water and sanitation, I personally think that there is a large body of knowledge and capability on how to build water and sanitation more effectively in India, and that the water and sanitation capability has not quite been mated into Swachh Bharat on the scale that it needs to be done.
Okay, Dr. Trehan?
So, like I said earlier, these are twins. We build on the base of Swachh Bharat, you could build a nice healthcare system. Ayushman would be much more successful. But there are certain simplistic, what worries us, and there are different accusations. I think Ajay can shed some views on that. There is a report from many villages that the toilets were built, but there was not enough water there. So they've all got filled up with you-know-what. And they are now spreading disease in the environment because they have become the breeding grounds for flies and mosquitoes. Is that true? Because you've been doing these surveys, did you find anything?
We're finding evidence of many of these facilities just being unused.
But not bad. Do you know anything? Because I've heard it from so many patients who come.
I think if I look at the reporting, yes, there is reporting of what you're saying, but I don't think there is data or evidence which says, okay, that, I mean, at this scale, I mean, there are some studies, but those studies are also disputed. So
I'm saying the implementation is
question I'm asking,
important.
no, the question I'm asking here is more conceptual. I'm saying that is this the first building block? Now we're heading to the end of our discussion, and if we are looking at now solutions, so is Swachh Bharat our first building block to get things going? And then we'll. That was really my question.
You know, it strikes you. You come to cities like, it started with Udaipur. I saw when we visited there was not a speck of garbage on the streets. You ask anybody, they say it's a city movement. Every Rediwala seller has come on board. They have their little dustbins. They come and collect. You go to Jaipur also this time today, noticeably it's improved. So where people have cared, they have made the difference. You take cities like Nagpur and Indore and all that, big difference. But you go to a city like Delhi, which is our capital, and you see stacks and stacks of garbage. Now who's responsible? So I'm saying that yes, it's a vast country. If you're going to hold a country as an example, use Sri Lanka. Sri Lanka has gotten rid of dengue. It's the most densely forested island. They've gotten rid of dengue. It's possible, but nobody cares.
Right, so yes, Maitreyi, if you wanted to come in before.
Yeah, so I just think that the fundamental philosophy, when you're talking at a conceptual level, the philosophy of Swachh Bharat is behavior change. And I think it's bang on track as far as that philosophy is concerned. So changing of norms, changing of values is possible, and they're given the right incentives and the movements. So I think that, yeah, absolutely.
Great, okay, let's get some questions. Wow. Where do I begin? Here. My request is keep your questions very short, preferably no comments, and maybe you can introduce yourself as well. Okay, she has the microphone. Okay, I'm sorry. Yeah, go ahead, go ahead. The lady with the microphone. Yeah. So I'm going to collect questions and then, yeah, yeah.
I'm a community medicine specialist myself. I'm not that old to have your experience, but whatever my education, change in states and working with NGOs, I have one line of thought which I've put to all the policy makers I've met in the past 5 years. I'll have 2 questions for you. First, all of you actually spoke of has one basic thing. I will not quote anywhere else, no other country, because I've not traveled abroad. For healthcare to work, you need one foundation stone, which is preventive medicine, preventive healthcare. And we as a nation don't have that. We do not have an institutionalized system, either in the government or in the in the public, private healthcare, that the preventive healthcare, that is someone who's responsible for it. When you say that the sanitation has to be improved, the water quality has to be improved, the air quality, the road traffic accidents and everything, people, if somebody else is there from my field, or sir would know, Dr. Trehan, that all of these things are broadly covered as a subject in preventive medicine or community medicine, as he say. As of now, all the people who are experts in this field are sitting in colleges. Because we in India, and as IAS officers also, we do not have that cadre. Any country that is working and is doing very well in healthcare, let it be...
What's a question? Yeah,
my question is that why have we, senior people, experienced people, why have we never, over the past 70 years, thought of that? That you need someone, a doctor, to start making policies. Okay. And what Dr. like I said, give me some time, please. Give me some time. The second question I'll ask is, no, 1 minute. That's okay, that's okay. The second question is, the title for this sitting was the last mile. I've worked with NGOs, I've worked in mobile health vans. Yes, we've not covered that. And that, as policymakers, everybody should be thinking, what are you doing for the people sitting in Uttaranchal?
I got your question. Okay, can you pass the microphone on? Yeah, first here, right. First row.
I'm quite senior, so I've got a different issue here. I work in the UK, I trained here, I've worked here for some time. I got both models in my mind. My question is, which is a very sort of very current problem in all health system, is end-of-life care. Okay. And that's become a big issue. I'm seeing people who family knows and the treating doctors know this is the end of life. The person is going to die. This is the dying process. And yet they are in hospitals and lakhs of rupees are being spent on that. I've seen that happen in my own family. And I hear stories all the time. And I would like to hear what the panel has to say about that.
Great. Okay. Here. There's only one microphone. Okay, I'll come back to you.
Hi. This is a question for Dr. Trehan, actually. The session is called Last Mile problem in terms of healthcare delivery. And we were talking about need for more regulation or behavior from private health care providers. The question I have is that once a patient is inside the hospital, there is complete lack of communication between doctors who are treating the patient and the caregiver or the patient. So how can this be improved to create more trust and reduce anxiety while patients are inside the hospital? Thank you.
Okay. Can you bring it here?
Hi, I'm from London. I work in disruptive vital sign technology, and I'd like to elevate the conversation a little and ask the panel, on the basis of what technology can do, i.e. we can identify conditions and illness within 2 minutes using technology, vital signs, etc. Where does the panel see the future of this technology? One initiative from each of you in terms of looking at disruption and changing the issues that are currently prevalent and stopping the prevention. One issue from each of the panel in relation to use of technology. Thank you.
Got it. Thank you. Yeah.
I just wanted to ask a question about the healthcare spend. My observation, having worked in, I'm a doctor, having worked in a number of countries in Asia and the Pacific and South Asia, is that an enormous area of wastage is facility degradation and lack of repair and maintenance of equipment. It probably, in most places I've been, the wastage probably represents about 20% or 25% of the healthcare dollar. What is being done in India to improve repairs, maintenance and the lifespan of facilities and equipment?
Okay. Yeah. Yeah. Last question, I think.
You mentioned Kaiser Permanente as a good model, but even in Kaiser Permanente, you have to pay, either you or your employer has to pay a significant fee to join the HMO. An alternative model is the British NHS, where the cleaner and the director of the institute where I work get exactly the same treatment and provides better outcome than the US for about 1/3 the cost. That's one question, whether that could be applied in India. And the second question is, with last mile, how will you persuade professionals at whatever level to go and live in villages to be part of these centers? That's, I think,
got it. Okay. So let me get some answers and then I'll come back. Maitreyi, do you want to go first?
2 points. One, there were 2 questions on patients' rights. And I think that's a really important point, whether it is for palliative care or hospice care or end of life or death with dignity and all of those things. I think we definitely need to do a lot more thinking about it because the family is the focus and the family makes the decisions. As far as patients are concerned, we're seeing the kinds of things that we are seeing. I wouldn't agree that NHS is necessarily the best model right now. NHS is in a crisis. But yes, Kaiser Permanente, you need to have pay in a significant fee. So yeah, both sides, yeah.
Okay, Dr. Trehan, I think there are a couple of points. I mean, one is, I think the technology question is interesting, right? Because finally, a lot of problems do get fixed by technology, if not, and we've seen that in other areas. So what could be the one technology disruption? And secondly, if I were to ask, and all of you really, I know that we've talked about last mile, but we've talked about fixing last mile from a top down. What's the 1 or 2 things that we should be doing bottom up that can?
So what the gentleman asked about how we can leverage technology to actually accomplish what we want to accomplish by way of universal health care, right? That's where India has a big advantage because the broadband has almost been connected to every village. Especially wherever we have located, we have identified the wellness center. So the wellness center will be part of a national grid where they will be connected to their district hospitals eventually, where 50% of the patients actually never have to be touched for diagnosis today because the enabling technologies are already present. So you can measure, of course, blood pressure, blood sugar, cholesterol, all these things you can measure right remotely now. Okay. You can examine patients remotely. You have scopes available. So I'm saying that that will be a game changer, if you want to use that word, because I think it should be put out of the vocabulary nowadays. It's too loosely used. But that will help this, and it's part of the scheme. I mean, it's part of the Ayushman scheme is to how to incrementally move that information from wellness center to the primary health center, to the district health centers, and then connected tertiary health center depending on the quality of care that is to be administered. So it is a very important point you raised about technology. That's one. 2, you know, like you said, you mentioned, there is no perfect system in the world today. America, which spends over $3 trillion on healthcare. That is 1.5 times our national budget. With 350 million people, 50 million people are out of the loop today. They don't have health insurance. So it's not that the challenge is not huge for everybody. But what we are saying is, somehow middle class income, I would say middle income people, will somehow manage, okay? But it is the people who are in economically weaker sections who are actually suffering. And human life is the same, whether you are poor or whether you are rich, it doesn't matter. As a nation, we must think of it as one group, and how do we provide them services? It cannot be done by one group or the other. You cannot say private sector will provide free care because they have to survive. So we need to look at a realistic pattern and say, get all the players on the same platform and say, how are you going to provide healthcare incrementally to all the people of our country? Let's sit down. Nobody's talking to each other. That's the problem. The government, I may be on the table, but as a larger nation, we must look at all our services together.
Maitreyi, bottom up.
So bottom-up approaches, I think that
so we are doing this. It's not like we don't have a bottom-up approach.
Absolutely. Yeah. I think with bottom-up approaches, the issue is of scale. So there are programs that are pilot programs. I mean, one of the most famous ones for neonatal care is Search in Gadchiroli. There are others. I mean, there's a program in Rajasthan that is Dusra Dashak, focuses very much on reproductive and sexual rights. So the role of information, of disclosure, of changing norms, changing behaviors on the ground is extremely important as far as community-based organizations are concerned. Yeah.
The gentleman asked this question about end-of-life care. Very important, because that is a turning point for where healthcare will go, also including the cost of healthcare. Okay. So often we are accused that life is being extended in private sector for gain. You must understand that no private sector will gain by extending this misery of a patient, because at the end we are spending more money on the patient than we are being paid, because that becomes the most expensive part. They are on a ventilator, they are on inotropes, they need 24-hour nursing. All sorts of stuff has to go into that. So that should be banished from the mind, that the patient's life is being extended because of any, I know you're not saying, but I'm just saying that's an often thing. Second, in the Indian community, when we talk about it's a family decision, the law says that the family collectively and can decide to say, do not take extraordinary measures. Do not resuscitate. Once somebody has a cardiac arrest, we know it's end of life, let it go. You can authorize. You can also say, don't go on a ventilator. But there is often conflict within the family. So how do we resolve it? We can't. As doctors, we can't. So again, I'm saying there is very little education, health education in our community. We do not inform, behavior patterns are different. And I'll tell you, many things. It's bad to give anecdotal things, but I'll tell you simply, there's a gentleman who is end of life. This family comes and says, can you not take out the ventilator for a minute? I have to ask him a number.
Okay.
This is the level we have to deal on the ground.
Right. So, okay, we're almost out of time. So there was one question about the maintenance and repairs. You think 20% in non-utilization or not effective utilization. Is that broadly is that an issue as far as you're concerned?
You mean 20%
machinery?
Machinery? No, we have excess capacity in the private sector. Institutions like ours run an occupancy of between 85 and 90. Most of them, one step below, will run 65, 70. So we can be leveraged.
Right. Okay.
We can be leveraged. And at reduced prices, but it has to be realistic. That's all. Because Ayushman prices today are not acceptable, because you are losing 30% on every patient you take in. So that's what has to be corrected, and then I think this scheme will be successful.
Right. Ajay, last word, 30 seconds, and then we close.
30 seconds. I want to say two things. The first is that the defining puzzle in India is low state capacity. Anything we think about in terms of solutions has to grapple with the fact that we have a very, very limited state apparatus, and it's not easy getting things done. And my second and last point is, we should understand that fixing health policy in India is a 25-year story. We should not look for 25-week answers.
Right, thank you very much on that. And I think let me re-emphasize the points that all of you have made, which is to focus on prevention, to focus on ensuring that we don't reach a point where we are running to the hospital to fix ourselves, because we will enter into transactional relationships with doctors, and focus on areas like food, air pollution, roads, and incentivize health. So the three things which I hope you take back, and hopefully you'll take better care of your health and not necessarily expect the government to deliver every time. Thank you very much.
We wish to thank Maitreyi Das, Ajay Shah, Naresh Trehan, Govindraj Ethiraj, and definitely we would like to wish our sponsors, Bill and Melinda Gates Foundation. Thank you all.